Good morning to you all. Hope you are doing well. First of all, I'd like to thank you all for the amazing support which you all have shown to me. And a couple of weeks ago, we managed to even cross the 1,000 subscribers mark. This, of course, is your channel, not my channel, because it's a resource for you all for uh, getting as much as knowledge in endocrinology and diabetes as possible. Before we move ahead, I'll just like to show you all first, because today's topic is about management of Cushing syndrome. So before you all go ahead to watch that video, try to have a listen to the Cushing syndrome diagnosis video, because of course the management is then a further continuation to how we establish a diagnosis. So try to have a listen to the Cushing syndrome diagnosis video, which is right up here. So let's now move on to the today's presentation, which is about management of Cushing syndrome. All right, so as I mentioned, today's video is about management of Cushing syndrome. Let's start off with the case number one. 38-year-old woman who complains of a 15 kg weight gain over the past year. She's a former high school gymnast who has maintained her weight in the past, including after she had given birth to her two children. So even after that, she was able to maintain her weight after the delivery. She now has history of irregular menses, polyuria, dry itchy skin, insomnia, increased irritability. Other medical history and past medical and family history was unremarkable. She is not on any medications like steroids. She only takes multivitamins. She's a non-smoker and has minimum alcohol usage. Physical examination and vitals show a blood pressure of 155 by 90 millimeter of mercury, face round and reddened, purplish abdominal striae with generally thin skin on examination. So far, if you all have seen the initial video of diagnosis of Cushing's, we know that we are dealing with the possible case of endogenous steroid excess here, which we will investigate further now. So lab investigation showed a fasting blood sugar which is elevated at 176 milligram per deciliter. This patient was not known to be diabetic, but was found to be diabetic during this evaluation. Cortisol after 1 milligram dexamethasone suppression test, which is the overnight dexamethasone suppression test, was not suppressed. In fact, it was elevated. Normally, it should suppress below 1.8 microgram per deciliter, but it was at 7.6. The 24-hour free urinary cortisols were clearly elevated at 220 microgram per day, where it should be less than 45. The ACTH was also high at 78 picogram per ml. So what are we dealing with? As you know from the diagnosis video, we are now dealing with an ACTH dependent Cushing's probably. Pituitary MRI showed a clearly 9 millimeter right lateral hypertensity, which is a microadenoma, as it is less than 10 millimeters. CRH stimulation test was done to further confirm the diagnosis of a pituitary dependent Cushing's, and it was found to have more than 50% increase in the cortisol post CRH. So based on all the above diagnosis, we clearly have a pituitary dependent Cushing syndrome, also what we call as Cushing's disease. So this is the scenario of case number one. Now, of course, our video is about management. So let's move on to the management. What's the first therapeutic intervention which we favor? I mean, here we are talking about a definitive therapeutic option. The answer is transpenoidal surgery. Okay, so now this is the very important chart which is given in the Endocrine Society guidelines, which is the main guidelines to refer to in regards to Cushing syndrome. Now, first of all, as you can see from the chart itself, that once you establish the diagnosis, we need to treat the comorbidities. So what are the comorbidities they are talking about? So many patients with Cushing's will have other psychiatric disorders, can develop like depression, mood changes, we need to treat that. Diabetes, hypertension, a frequent accompaniment with Cushing syndrome, we need to treat that as well. Hypokalemia can happen, especially in ectopic Cushing's. Other infections, they are prone to other infections. Also, we should remember one thing, that they are also prone to deep vein thrombosis or thromboembolic episodes. So anticoagulation, prophylaxis like heparin, low molecular weight heparin, is also essential in this group of patients. Dyslipidemia can happen. They also can develop osteoporosis and, of course, a poor physical fitness. So we should always take into consideration his comorbidities right at the beginning after we have established a diagnosis. Of course, we are looking to do a definitive treatment for our patients of Cushing's, but we should not ignore the associated comorbidities, because that comorbidities are the most troublesome and the most common cause of mortality and morbidity in these patients. So we need to look to treat these comorbidities right at the beginning. So now, as in our patient, as you see, I have marked the red arrow here. So we have in our case number 1, an ACTH dependent Cushing syndrome. So just look at this graph, follow it down. Presumed Cushing's disease, either if it is a mass more than 6 millimeters. So our patient had a 9 millimeter mass. If it is not more than 6 millimeter mass in the MRI, then we need to do an inferior petrosal sinus sampling. Again, which is clearly described in our diagnosis video of Cushing syndrome. If it is more than 6 millimeter mass, then, and if the biochemistry and the clinical features are clinically showing Cushing syndrome, Cushing's disease in terms of ACTH dependent, we can proceed with tumor resection. So that's why that is the answer of the question number 1. What is the definitive treatment for this patient? It is tumor resection, or basically a transprenadal surgery of the pituitary microadenoma, which was found in this patient. Now, we'll look at the other options later on, but we'll go step by step in terms of getting an idea how to proceed with the management. Okay. Now, clearly, if the patient has a tumor resected, and if it goes in the remission, we'll just monitor for recurrence. If the patient does not go into remission, if there is a failed surgery or opted for no surgery because of other comorbidities or recurrence after the surgery, in all these cases, we have to then think about controlling the hypercortisolism with other options. So if you look at if it is Cushing's disease, like if it is a pituitary dependent cause, we should consider repeating transprenadal surgery. We should consider using other pituitary directed medical treatment. We'll look at that in the next slides. Consider radiotherapy or steroidogenesis inhibitors. For all other etiologies, like for ectopic cause or for adrenal cause, then we need to look for other options like steroidogenesis inhibitors or glucocorticoid receptor antagonist or bilateral adrenalectomy in that regards. So this is what we need to know from this chart. Okay, we look at the other options step by step. So Endocrine Society recommendations are very clear. They recommend resection of the primary lesion. Now in our patient, it had a pituitary microadenoma underlying Cushing's disease. And now if it was an ectopic tumor or an adrenal tumor for that matter as well, again, surgical resection is what is recommended by the Endocrine Society. Unless and until surgery is not possible, or if it is unlikely to significantly reduce the glucocorticoid excess. But the first step for all these causes of Cushing's syndrome is surgery, which is resection of the primary tumor. Now, how do we prepare the patients for the surgery? Okay, and also we look at the post-op management and the pre-op management for these patients. So this basically what is generally done, irrespective of the cause of the Cushing's. Hydrocortisone coverage is given, which is 50 to 100 milligram IM or IV, 6 hourly, pre-operatively, and this is continued after the operation as well, till the patient is eating and drinking normally. Once the patient is eating and drinking normally, he is converted, the IV or IM hydrocortisone is converted to oral hydrocortisone. In the first 1 or 2 days, slightly Higher dose is given, which is 20, 10, 10, and then is converted to the physiological dose of 10, 5, 5. Perioperative glucocorticoid therapy entails virtually no risk for the patient. Pre-treatment can be given, okay, and again, this is not required in all the patients, but in very hypercortisolemic patients, if they are sick, then pre-treatment may be given with drugs like metyrapone or ketoconazole to improve the condition of the patient. Now, this will allow some improvement in the healing and also improves the general state of the patient. One important point to note here is in critically ill patients and in acute emergency setting, we can use IV etomidate, which blocks the beta hydroxylation and in fact can be life-saving. Perioperative prophylaxis for venous thromboembolism, I mentioned that, should be clearly used in patients with Cushing's undergoing surgery. So this is again very important. Perioperative prophylaxis for venous thromboembolism with heparin. Heparin is extremely important in patients of Cushing's undergoing surgery. So we need to keep this, and we'll discuss all of these drugs in the subsequent slides. But to get an idea, pre-treatment with metyrapone or ketoconazole can be used, not used in all the patients. In critically ill patients, we can use IV etomidate, which quickly brings down the cortisol and is life-saving, and it is a drug of choice, especially when the patient cannot tolerate any oral medications. What happened to the patient post-operatively? So post-operatively, day 3, she complained of polyuria and polydipsia. Her urine output was noticed to be more than 5 liters over a period of 24 hours. Investigation revealed a high sodium at 148, potassium was okay, urea slightly starting to go up, creatinine gone up 124, calcium was normal, calcium was 2.71 as well, borderline high, and random glucose was 8.4. Now, based on all this case, in terms of the immediate post-operative complication, which we are looking at and which we should keep in our mind is, so the free view of this particular lecture has ended. For access to this full lecture session, please subscribe to my lecture series, which is total of 60 lectures till date. These will be provided access to via paid subscription plan, and all the paid subscribers will be given a lifetime access to all my existing 60 videos lectures, which are already on the YouTube channel, plus all the upcoming new videos. So whatever lectures or sessions I'll be doing in coming weeks, months, and years, all of them will be given access to in the same subscription plan. So for the full subscription details, please email me on mazirules@gmail.com or WhatsApp me on 009715574344794 and have the same number on the Telegram app as well. Just to give a brief overview of the full lecture series, so it includes different topics across diabetes and endocrinology. For diabetes itself is around 19 lectures which I've done across different topics which are useful for the exams as well as for the clinical endocrinology practice. In terms of high yield topics for specialty exam and European board exam, there are around 9 sessions which have covered all the previous exam recalls as well as all the high yield topics and themes which are frequently encountered in the specialty exams and the European board exams. In terms of thyroid, apart from the thyroid cancer guidelines which were recently published, plus there are other sessions on different topics related to thyroid across the spectrum of thyroid disease. In terms of adrenal as well, covering all the important topics or sessions which are frequently encountered in exams and in clinical practice. There are 2 very good sessions on lab endocrinology by Dr. Velmurugan, very helpful for those preparing for DM Endo or DNB endocrinology as well. In terms of pituitary, also have covered all the important sessions on all the important topics which are frequently encountered in clinical practice and the exams. There are a few sessions on the inherited endocrine syndromes as well. Very important sessions on reproductive endocrinology, about congenital adrenal hyperplasia, gynecomastia, hirsutism, PCOS, diagnosis, evaluation, management. There is a sessions on calcium and bone metabolism, on familial lipid disorders, and sessions on pediatric endocrinology as well. So just to let you know that there are many more sessions coming up, and as I mentioned, that in the same subscription plan or same subscription fee, you will be provided access to all my existing 60 lectures plus all my forthcoming lectures. So thank you very much for subscribing. Thank you very much for supporting.